We are moving to our last session speakers. David Hebert. David is ECMO coordinator of Our Lady of the Lake Regional Medical Hospital. So please, David.
Good afternoon. My name is David Hebert. It looks like Hebert is very French, so if you mess it up, it's really not a big deal. So I'm the ECMO program manager at Our Lady of the Lake Hospital, Baton Rouge, Louisiana. We launched this program about a year ago. Before that, I spent, thank you, the majority of my career at Children's Hospital in New Orleans. So the opportunity to jump to adult care was really, I first got that first phone call and I'm like, no, thank you, I don't do adults. But it's been really great because I learned a lot of different ways of managing ECMO and especially ventilation. So let's see if I can work this. So I have no financial disclosures today. So today we're going to review some of the human cardiopulmonary physiology and pulmonary dynamics, modes of ventilation during ECMO, and lung recruitment strategies. So just a refresher, we know cardiopulmonary stands for heart and lung process. And some of these things you guys know, I just want to hit home pretty hard about this. It does get back to be relevant further in my talk. We know what PEEP is. PEEP is positive end expiratory pressure, keeps our alveoli open. Alveoli has to hit the capillary bed at the right pressure to make sure we have proper gas exchange or have VQ mismatch. Anatomical PEEP for neonates is about 3 centimeters of water, and for adults is 5. So just, we know that once we intubate anyone, we lose that anatomical PEEP. We have to make it up through a ventilator and making sure that we don't create anything called inadvertent PEEP, which could be caused by a poor IE ratio, high ventilator pressures, and/or, which I see quite often, is water in the expiratory circuit or limb, which creates auto PEEP. So those are things we always want to watch out for. And again, FRC, functional residual capacity, is the same thing as PEEP. We know what the trachea is, right? The tube connects the larynx to the bronchi, and the bronchioles connect the bronchus to the alveoli. Alveolar capillary bed. So when we're doing ECMO or perfusion, we don't have to worry about this so much because we have oxygenators. They have the best diffusion ever, right? You have that perfect connection of alveolar capillary bed consistently until the oxygenator goes bad. So just a reminder, again, I can keep saying reminder, when we're trying to ventilate these patients on ECMO or even not on ECMO, making sure that PEEP is right for that patient. Not every patient is the same. And got to remember, is there some kind of congenital anomaly with the patient? There's something else going on that we may need higher PEEP or lower PEEP. Or are they a congenital cardiac patient who, I remember my pediatric cardiac surgical unit, PEEP was a bad word. So a lot of times we had patients come out of cardiac surgery with no PEEP. And from an RT perspective, it's like, what are we doing? But it works, right? And then the bronchus, we know the bronchus it delivers airways. You have a right main stem bronchus. Again, going back to congenital defects, it could make a major difference in how you ventilate your patients. A couple of diagrams. I just gave a lecture at LSU to the respiratory group, so I just brought these back in as a reminder. We know what the lungs look like, and I think people tend to forget that alveoli, right? We have millions of alveoli. It's not just one big balloon, and so if you have one small cluster of alveoli, it doesn't work. It can really greatly inhibit your VQ performance. Again, I did a picture of blood vessels, and just remembering we have so much going on at the same time to look at while we're ventilating these patients. So when we talk about pulmonary compliance, so pulmonary compliance is the ability of the lungs to stretch and expand, happens every day, every second we breathe. This is what's going on. It depends on our altitude. I'm from Louisiana, so we're below sea level. If you're in Colorado, you're way above sea level. It makes a difference. When it comes to ventilation, we look at static and dynamic compliance. So static compliance is the ability of the lungs to stretch and expand during no airflow, during expiration. So kind of want that to be kind of really low. It should be really comfortable for the body to maintain that. And dynamic compliance is the ability of the lungs to stretch, expand during air movement when we breathe. So do you have a restrictive or any kind of air or pulmonary, again, congenital issue? Or you have COPD? Are you an asthmatic? It makes a difference. So these are things we should look at. Again, every patient is different. So as an RT, I'm a bit nerd. I like, when I open up a ventilator, I like to look at full volume or pressure volume loops. I think it tells you a lot what's going on in your patient, even without looking at the ventilator readings. So if you look here, it's a very simple, basic look at pressure volume loops. And if you look to the left, It shows how it's in more of your normal range, and then as it decreases to the right, you have decreased compliance. So that's one thing to kind of remember. If you do have ventilators that have flow or pressure graphics, turn them on, and then if you know something about it, maybe educate the rest of your team, because it is something really beneficial to know. I often use this when we're trying to wean from ECMO, and are we ready to come off, and I'll open up the compliance on the ventilator, and it's shifted to the right and never moved in the last 3 days. So guess what? We're not ready to come off. We're not ready to do anything with this patient. Just thought this is a pretty cool graph or image to show a video, just inspiration, expiration. We know this, right? We breathe in, create negative pressure, active process. We exhale, diaphragm goes back up. Again, it's active, but so this constant of air exchange, blood exchange through the capillary bed, and just something we do, again, every day. Modes of ventilation next. So one thing I want to talk about before we talk about modes is lung recruitment. So show of hands from your ECMO centers, how many of you guys use like really strong lung recruitment to come off ECMO, as far as like increasing PEEP, doing aerosol treatments, IPV, anything like that? No? Anybody do it? Yeah? Okay. Anybody do a lot of passive lung recruitment on ECMO to get your lungs better? No? Okay. So looking back, we look at resting vent settings, and, I was supposed to make a joke at Giles, but he left already, about the Caesar trial back in 20-something years ago, talking about 30%, 10, 10, and 10. And that still holds true to this day. From the pediatric world, I grew up doing 40%, rate of 20, 10, and 10. Now that I'm doing some work in the adult world, it's 40, 10, 10, and 10, basically letting the lungs rest, right? And we know this. I think I'm going to get on my soapbox for a minute, but I think a lot of programs that we talk to people that, they forget to let ECMO do its job, right? Let the lungs rest, if it's a pulmonary issue, especially. If it takes 2 weeks to open up the lungs, and it takes 2 weeks, it's okay. I just find people try to rush that. So talk about, lung recruitment, pulmonary toilet, right? Airway clearance, aerosol CPT, IPV, you can bronching. We bronch our patients at least, once a week if we think it's mandatory, if we think we got something not mandatory, if it's beneficial. And a lot of places will increase vent settings after a while. Say, hey, does our X-ray look a little better? Is our blood gases look good? Do you want to go up on our pressures? Do you want to go up on our PEEP? It varies. So I think there's one thing I've always spoke to my team, that ECMO is like many things, but it's very different in every institution, right? So you may go across the street, like the Bob's ECMO Center and car care place, and they may do ECMO a very strange way to you, but it works, right? So respect that. And I think that's the beauty of what we do, is that we all do something a little differently, but it works. So modes of ventilation. So assist control ventilation is when the ventilator delivers a set number of breaths, and the patient can also trigger assisted breaths. Can be either pressure or volume controlled. SIMV, synchronized intermittent mandatory ventilation. The ventilator delivers a set of number of breaths, and the patient can also trigger assisted breaths. Can be either pressure or volume controlled. That sounds the same, right? So it's a little confusing, like, what are we talking about? What is going on here? You just said the same thing twice, David. So, okay, I didn't do that yet, sorry. So assist control versus IMV. So assist control, the patient can trigger a breath, but what's going to happen is going to get the same breath as the delivered breath, the same amount of volume. Or so if it's in if it's pressure control, you get to hit that same pressure. When that pressure hits, you get whatever volume you get due to your lung compliance. And SIMV, the beauty of that, or SIMV and pressure support, is that when that patient takes the breath, between those 10 breaths a minute, they get their own tidal volume. So having pressure support, which all pressure support does is augments the spontaneous tidal volume, helps the patients grow their lungs and get a little bit stronger. As just a reminder, if those of you not respiratory therapists, or just maybe haven't thought of it this way, pressure control, you set a PIP, right? You set a total PIP, and a volume, you get a volume. It varies again due to compliance. And then the opposite of that is volume control. You set a volume, and your PIP varies. And I think nowadays everyone's going to pressure control for their patients on ECMO. But I remember early in my days, I had hair back then. I think, we did volume in some patients, and we realized, whoa, these pressures are crazy. What are we doing? So, we learn as we go. But I think most people do a pressure nowadays, and it's just easy to. What I teach some of my students is that it's just like on ECMO, you have RPM set. And volume varies because of preload or afterload. So kind of think of it that way. And it's a good transition, especially from respiratory therapists who become ECMO specialists. So if you look at these wave volumes. You look at assist control, and so you see it goes up as inspiration, you come down as expiration. And that's a very weird way to breathe. You're like as if you're just running down or running up stairs, right? It's not very comfortable. Most patients are sedated, some are not. But if you look at this as SIV mode, you have that really weird square wave, which is really uncomfortable. You have these two little squiggy lines in the middle, and that's the patient generating a breath. That is really beneficial. Again, their lungs get a little bit stronger, a little better compliance towards the end. So I think using SIV is much more efficient than assist control. Another mode of ventilation came out probably about 2010, 2015 is APRV, airway pressure release ventilation. It's a pressure control mode of ventilation which delivers the most continuous positive pressure with intermittent time cycle short releases at lower pressures. So we prefer to use these in spontaneous breathing patients. Utilization of longer inspiratory pressures which increase mean airway pressures to improve oxygenation. Brief release at a lower pressure allows for CO2 removal. Really just causes a lot less stress in the lungs. And this way alveoli do not always completely collapse. Even if you have a certain amount of PEEP dialed in your ventilator, your alveoli can still collapse. So what happens with this mode, and this might be easier to show here, is when you're breathing in, so patient breathes in, right, delivers the breath, you get this plateau, this what they call T-high, and it sits there for a couple of seconds. When the patient exhales, it doesn't quite go to baseline, even to that PEEP baseline. It'll vary a little bit. So you have a little bit better for lung recruitment and a little bit better gas exchange. So it seems to, again, cause less barrel trauma. If you look to the right of this, it kind of shows a small, kind of like a flow volume loop type of showing kind of that sweet spot of what that pressure should be for the patient. Again, it's better for patients who are breathing or spontaneously breathing. It works a little better with the flow control and dynamics of it, but it does seem to do relatively well. Next, again, growing up in a neo-ped center, I saw lots of oscillators, so high frequency oscillator ventilation, oscillation, consistent high distal pressures with the PEEP with very high rates, which are hertz, and low tidal volumes. So basically, an oscillator is just a big PEEP machine, and it can be kind of scary because if you don't do it right, you will have a couple of pneumothoraces before you go to lunch or before you finish your shift that day. So MAP is basically just PEEP, breath rates between 180 and 900 a minute. Tidal volumes less than dead space. Alveoli remain open if you have the right settings, of course, and then you just need to be careful because increased MAP is basically too much PEEP, which happens with too much PEEP. We have decreased venous return. Even on ECMO, that is still not a good thing. We would do this occasionally on our diaphragmatic hernias who were a little bit too sick to come off conventional ventilation, even right when we went on ECMO, and we may leave them on for a couple of days and try to transition to conventional ventilation. A lot of times also, even if we would repair on pump, we may put them back on oscillator to get them off. That way have that consistent pressure and less beating up of the lungs. So here you can see the dynamics of conventional ventilation versus oscillator. You can see on the left side, we have these wide, what they call them, swings of pressure between inspiratory and expiratory phase, right? So if we take a breath in, a lot of pressure in the lungs, breathe out, man, that feels good for the alveoli. There in oscillator, we have the just constant pressure of blowing air or blowing volume into the patient. And you can see again on the right side, it shows a little bit. What happens with an oscillator really is a biphasic flow in like a dual lumen cannula in theory. So you have the oscillator circuit, which I'll show you, kind of like this. It's a big, ugly, scary machine. You roll it in. It's loud. It's obnoxious. It takes up all the room in the unit or in the patient's room. So you have flow going to the patient. On the center of the circuit, you have inspiration. And as the patient exhales, which is passive on oscillatory, it's along the sides of the tubing. So it doesn't really interfere with each other. And it works really well. The good thing with oscillators is, with our practice and probably most places is if you take them off the oscillator to maybe bag and suction, which some places that's a yes or no kind of thing, we would put it back on and we'd increase the MAP or the PEEP about 1.5 of what it was before to kind of re-recruit that alveoli. And kind of almost the same thing when we go from conventional to oscillator. If your patient's mean airway pressure was probably 10, we're probably starting about 12, and just make sure we didn't flatten the diaphragm. We had good gas exchange, and again, we didn't cause too much decreased venous return. High frequency jet ventilation. We had one of these for about 3 weeks. We rented it, had one physician champion, and realized we don't like it. It's mostly for neonates and really for patients who have air leak syndrome, like pneumothoraces. Works really well for that, though. Again, high respiratory rates, less than dead space. Difference with this and oscillator is that main thing is this is more for ventilation than oscillation, or oxygenation, excuse me. So you can see what happens. These are used in tandem with a conventional ventilator. A conventional ventilator sets a rate of about 6, depending on what you like. And that is basically just a sigh breath to help blow off more CO2. And again, a little bit chest rise too. So you can see as the high pressure starts, and it just as the airways get narrow, like from the bronchus to the bronchioles, which I said a minute ago, which seemed kind of boring. That pressure just tends to drop, but it doesn't. What it does, it doesn't cause any further barrel trauma to the lungs. That's the great thing about this ventilator. It really, if it's used properly, it's good for your patient's lungs. This is what it looks like. It's really heavy. It's obnoxious. Again, it's loud if it goes off. And the difference with this ventilator compared to any other ventilator is that you have to put this back on the patient's ET tube connected before you start it again, because it tries to generate pressure against resistance. So if you have it open up the atmosphere, you put it in your patient, you're going to have the largest pneumo you've ever seen in your life. So you have to put it on the patient first, then start it up. So it's a great learning curve. So we've talked a little bit, mostly about, recruiting lungs, and so passive lung recruitment. So when I went to Baton Rouge a year ago to start the ECMO program, I met the doctor for the first time. Hey, nice to meet you. I'm David. Hey, your name is Owen. Hey, nice to meet you. Let's do ECMO together. I hope it works. And so I prepared all of these documents and policies about how to do lung recruitment on ECMO. And again, coming from the neonatal world to the adult world, trying to, learn, okay, so bigger tidal volumes, bigger ET tubes, right? Maybe more pressure. And sat with him, all these great policies, IPV, this and that. And he goes, nope, I believe in passive recruitment. I'm like, okay, sounds good. All right, nice working with you. So it's been quite a challenge to sit back and go, okay, I learned something new, David. Eat your words, practice what you preach. Everything's a little different. And I have to say, I had my doubts, but it works well. We just took a lady off, was on ECMO for 52 days, postpartum, flu A. And about day 20, I thought, okay, I'm going to show him that I was right. So Sunday, I turned the ventilator up a little bit. He slapped my hand. Nope, don't do it. Okay. So we spoke to some friends out in the field, right, just like you guys. And what are you guys doing? Are you seeing any patients with flu or having trouble coming off ECMO? They're like, yep, some weird strain this year. We can't get them off, and we do recruitment. We don't do recruitment. I'm like, okay. So again, David, shut up, eat your words. Everything's going to work out. And so, we got her off on day 52 of ECMO on resting vent settings, 40%, rate of 10, delta P of 10, and 10 of PEEP. And 3 days later, she was on trach collar. 5 days later, we pulled her trach out. She's sitting up and talking. So my point is just to talk about, again, the various variations of how we all practice with our patients. And these patients, we did some benchmarking and similar run times compared to patients who have really this rigorous recruiting process. And then, again, less barrel trauma. They seem to do quite well with that. So this is a pretty short talk, so thank you for your time. And if you have any questions, I'm more to entertain them at this moment.
Thank you so much for your presentation. It was really informative. So, any questions from the audience? Any? Yes.
The first ventilator I came across would have been an East Radcliffe ventilator, which was driven by a bicycle chain, and the cam went up and down, and it kind of worked. Do you think ventilators have got a bit too clever for their own good? Because when I worked at the Brompton, we would go out on ECMO retrievals to hospitals slightly outside their comfort zone, and they would have put them on a ventilator, and I can't remember the mode now. Not on ECMO, but just on the ventilator, and the ventilator was really compromising their oxygenation because the pressures that we're using was contraceptive.
I get you, yeah. So being old school, I do think ventilators nowadays are a little bit too complex. I think I prefer to have a ventilator that I grew up on. You set an I and an E time, you set your flow, and you ventilate that way. I think what happens is they're great. Let me watch what I say. I think they're a little too preset for these preset settings for their ideal patient. And I think sometimes we just tend to miss those things as clinicians and think it's going to work on this patient because it worked 5 minutes ago on our other patient. But I do agree. I think we just need to be a little more, I guess, vigilant what we do when we set them up. Yeah, if that answered your question or not, but yeah. Yeah.
Hi there.
Thank you.
So my question is, do you find it more patient-specific on ventilator settings that work best for them, or do you find specific disease patterns of the lungs react better to different ventilator settings? Because I worked in the ICU for 10 years, and man, respiratory therapist, God bless you. But I always kind of wondered that if it was, instead of having like a generic protocol number, could we have something that, like you said, where you looked at their tidal volumes that they normally do?
Right. Answer is yes. No, I think, I think, right. So every patient is different. So I think it varies, as what you said, on the patient and their disease process. We had kind of what you're saying. We had different algorithms for their BPD and their diaphragmatic hernia, their ABC, whatever. So I think just having those kind of pre-built are good. But then again, look at your patient. So yeah, it's hard to say. Yeah.
So one question. Cool.
Any thoughts about using HELOCs in ventilators?
Heliox.
Yeah.
So I've used it before. I didn't see much difference in the patients we used. We used to use it in asthmatics because it's supposed to lighter gas, get better to alveoli, all that stuff. I wasn't a big fan of it, to be honest with you. It may work in the right patient, but I never saw anything really beneficial. And I've never used it in the ECMO patients either. So yeah.
Just to comment on the Heliox, most of the time, by the time you find it, your problem is already solved.
Yeah.
Thank you so much, Dave.
Thank you.
Thank you.